Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Okay, let's unpack this. Imagine for a moment facing one of nature's most primal fears, snakebite. But beyond that immediate terrifying moment, what truly happens inside the body as venom begins its work? And how do medical professionals, armed with sophisticated science, race against the clock to save a life?
Indeed. What's truly fascinating here is how much our understanding of snake envenomation has evolved. It's gone from simple folklore to a highly intricate science. It's a remarkably complex clinical scenario far beyond just venom and fang marks. Today we're diving deep into that intricate world, exploring everything from the nuances of snake classification to the molecular marvels of venom itself, and critically the cutting-edge treatments that are transforming patient outcomes across the globe.
Right. And our mission in this deep dive is to take a stack of highly detailed medical and scientific sources. Everything from precise taxonomic breakdowns to critical care protocols, and really distill it. Distill it into the most important, impactful insights for you, our curious listener. We'll be your expert guides through this often surprising and at times startling body of knowledge, giving you a real shortcut to being thoroughly well-informed about a topic that surprisingly impacts millions globally every single year. Let's jump right in.
So when we talk about snake envenomation on a global scale, it's absolutely crucial to understand that this isn't just, a rare sensationalized incident you see in movies. It is unequivocally a critical global public health challenge. It's particularly devastating in rural tropical regions where access to rapid quality medical care is often tragically limited. Our sources are very clear on this. Snake envenomation is considered the most significant cause of major morbidity and mortality among all terrestrial venomous and poisonous animals.
Wow. That's a truly staggering statistic. When you really dig into those numbers, it hits home with remarkable force. We're talking about snake bites killing more people annually than bites from spiders, scorpions, or, anything else on land that's venomous. The estimated global incidence of snake bites ranges widely, but some reports suggest it could be as high as, 5.5 million bites worldwide each year?
That's right. And out of those, a significant portion, approximately 2.54 million, are confirmed venomous bites. And the human cost of these bites is absolutely devastating. Annually, globally, we're looking at an estimated 400,000 amputations and approximately 100,000 deaths.
100,000 deaths.
Yes. And it's important to note that initial global fatality estimates, which sometimes hovered much lower, maybe between 20,000 and 94,000, were actually severe underestimates. For example, highly detailed studies from India alone determined at least 45,500 snakebite deaths yearly just within that single country. This starkly suggests that the global annual death toll is indeed at least 100,000, possibly more.
So what does this all mean for you, our listener? These aren't just distant, abstract numbers. These numbers highlight that snakebite isn't some exotic, far-off problem. It's among the top 10-15 most important health problems in certain rural tropical areas. And these are often the very regions that are already struggling with a severe lack of medical and financial resources. Well, it's a profound global health inequity, isn't it? A kind of silent crisis that compounds existing vulnerabilities.
It absolutely is. That's a crucial distinction. If we connect this to the bigger picture, it underscores the profound difference that modern medical care and accessible antivenoms make. Just consider the stark contrast with the United States. Here we see approximately 5,000 to 9,000 emergency care visits annually for pit viper snake bites. Yet, mortality is extremely rare, with fewer than 10 deaths reported per year.
Fewer than 10. That disparity between global deaths and Western outcomes is truly jarring. It really makes you wonder about the impact of accessible healthcare and resources. It's not that the snakes in the U.S. are inherently less dangerous than their counterparts elsewhere. It's about the infrastructure, the medical capacity to respond immediately and effectively. It almost sounds like modern medicine has largely solved the immediate biological threat, but the real challenge is socioeconomic and logistical. Is that a fair assessment?
Absolutely, that's a very fair assessment. The why behind these vastly different outcomes is almost entirely access.
Yeah.
Access to timely, effective treatment, particularly anti-venom. And we're not just talking about the anti-venom itself, we're talking about basic infrastructure, roads, electricity for refrigerating medicines, trained medical personnel who can identify symptoms and administer treatment, even just sterile needles. It's often a systemic failure in many regions, not just a supply issue. #, snake classification and the venomous divide.
So we've painted a picture of the global challenge. Now let's turn our attention to the source of the problem, the snakes themselves. Globally, there are roughly 3,000 snake species identified. But here's a truly surprising fact that cuts through a lot of public fear. Only about 600 of those 3,000 species are actually considered clearly venomous. That's a relatively small percentage, which, puts things into perspective a bit.
That's right. And these 600 or so venomous snakes are classified into several important families: Colubridae, Atricidae, Elapidae, Lamprophidae, and Viperidae. Beyond these broader family classifications, we also categorize them morphologically, which means based on their physical structure, particularly their fangs and how their venom glands are organized.
Okay, so let's look at those fang distinctions. First, we have the front-fanged venomous, or FFV, snakes. These are the ones you typically think of when you imagine a dangerous snake, like the classic cobra-type snakes from the family Elapidae and the vipers from the family Viperidae. Their fangs are positioned right at the front of the mouth, ready to strike.
Exactly. And critically, their venom glands are typically high-pressure glands. This allows for very fine-tuned, almost surgical venom ejection. Think of it like a hypodermic needle with a controlled plunger. This precision gives them incredible control over how much venom they inject during a bite, which is a key evolutionary adaptation for, well, effective predation and defense.
Right, and then you have these fascinating non-front-fanged colobroids, or NFFC snakes, which often get dismissed. This group includes what people might call back-fang snakes, or even those with no clear fangs at all that you'd readily identify. Their venom, if they produce it, comes from a low-pressure, elongated gland called Duvernoy's gland. What does that mean for how they deliver venom, and why does it matter clinically?
That's a critical point. Unlike the high-pressure system we just discussed in the FFVs, their low-pressure glands mean they have far less precise control over how much venom they inject. This imprecision often leads to less effective envenoming in a bite. Historically, many NFFC snakes were even considered non-venomous entirely. However, revised taxonomy now recognizes that some NFFC species are venomous and have caused human fatalities or major envenoming, which is a significant and evolving update in our scientific understanding.
And speaking of scientific understanding, there's actually an ongoing, quite lively debate in toxinology about what truly defines venomous. It's called the toxicophera hypothesis. It proposes a much broader definition that could potentially include almost all snakes, many lizards, and even other vertebrates.
Right, it raises an important question. What truly defines venomous? The debate around the toxicophera hypothesis highlights that the boundaries are far more nuanced than simply, does it have fangs? And it speaks to the continuous evolution of scientific understanding. While it's an interesting, maybe provocative hypothesis from a biological standpoint, it's important for our listeners to know that for practical clinical relevance in treating snake bites, it's largely rejected by the majority of toxinologists. Our focus remains on the snakes that pose a clear and present danger to humans.
Okay, so let's zero in on the major players, the truly medically important snake families that cause the most concern globally. First up, the family Elapidae, often thought of as the neurotoxic specialists, but as we'll see, they're actually more diverse than that.
Indeed. Elapids are a large, diverse family of exclusively venomous snakes found on all continents except Antarctica, and even in several major oceans, including many sea snakes. They possess those well-developed fangs we mentioned earlier, positioned towards the front of the mouth, capable of delivering often highly potent venom.
When you think of elapids, the iconic Indian cobra often comes to mind, right? Though not all elapids have that iconic hood. Medically significant examples, the ones that cause serious problems for humans, include Australian death adders, kraits, mambas, cobras, and taipans. Even sea snakes are part of this family, specifically the subfamily Hydrophinae.
Clinically, elapids are a major cause of snakebite morbidity and mortality globally. In the United States, our key examples are the coral snakes, found in the genera Micrurus and Micruroides. They are primarily known for causing neurotoxicity, which means their venom attacks the nervous system. This can lead to alarming effects like blurred vision, tingling sensations called paresthesias, drooping eyelids that's known as ptosis progressive paralysis, and potentially fatal respiratory failure, which is especially critical in regions lacking intensive care facilities.
Yeah, exactly. And here's a truly crucial and often misunderstood point about coral snakes. They often inflict this severe systemic neurotoxicity without causing significant local tissue damage at the bite site. This can be incredibly tricky diagnostically because the visible signs might be minimal, like just a small bite mark or maybe mild swelling, but the internal neurological effects are severe and rapidly progressing. For instance, the eastern coral snake's venom toxicity is mainly due to specific neurotoxic PLA2 enzymes. It's a silent but potentially deadly threat.
Right, a silent threat. Next, we have the family Viperidae. These are sort of the hemorrhagic and tissue-damaging powerhouses. This is another large, diverse family of exclusively venomous snakes found on most continents, excluding Australia, New Guinea, and Antarctica. They possess a highly evolved fang structure with mobile fangs at the front, allowing them to fold away when the mouth is closed, making way for impressively long fangs.
Okay. And within Viperidae, there are two main subfamilies. First, the Viperinae, or Old World vipers. These are your classic vipers, like Russell's vipers in Asia, which are notorious for their severe effects, and the puff adder in Africa. Their venom is potent. It can cause severe local tissue injury, serious blood clotting issues leading to widespread hemorrhage, shock, and sometimes even neurotoxicity.
And the second subfamily is the Crotalinae, or pit vipers. These are characterized by their anteriorly placed heat-sensitive pit organs located between the eye and nostril. They use these to detect the warmth of prey, even in complete darkness. It's quite amazing. This subfamily includes the rattlesnakes, cottonmouths, and copperheads, which are extremely relevant in the U.S. They're responsible for the vast majority of venomous bites here.
Right. And when we talk about clinical relevance in the U.S., pit vipers are indeed the most common cause of venomous snake bites, accounting for over 98% of cases. Their venom is complex, typically causing significant local tissue inflammation and swelling, edema, widespread hematologic effects like coagulopathy, those blood clotting disorders, hemorrhage, bleeding, and thrombocytopenia, low platelet counts. And yes, some can even cause neurotoxicity, which really challenges the old, simplified notions of venom effects, doesn't it?
It really does. Among U.S. crotalines, rattlesnakes are associated with the most severe clinical presentations and account for almost all deaths in the country. Very few, thankfully, but still, mostly rattlesnakes. Copperheads, Acastrodon contritrix, on the other hand, are the most commonly implicated pit viper, responsible for maybe 45–52% of bites annually in the U.S., though their bites are generally less severe and rarely fatal, often leading primarily to local tissue damage.
You know, what really blows my mind here is that a snake's venom isn't static. It's like a personalized biochemical signature changing with age or geography. This venom variability is a crucial point. Pit viper venom composition, potency, and quantity can vary significantly based on the genus, the exact species, the age of the snake you mentioned. Young snakes can have different venom than adults.
That's right, sometimes even more potent.
Wow. And their diet, the climate or season, and even specific geographic location. Even within the same species and location, dynamic variation can occur. And this impacts clinical presentation and, crucially, antivenom efficacy. You mentioned some venoms might have high metalloproteinase, SVMP activity, but lower overall lethal toxicity, which you called type 1.
Correct.
While others have low SVMP but high lethal toxicity, rich in PLA2 neurotoxins type 2. How does that biological variability complicate how we even think about antivenom effectiveness?
That's precisely the challenge. This inherent variability within snake venoms is what makes diagnosing and treating snake bites so incredibly complex. It forces us to question assumptions and consider that even seemingly identical situations can have vastly different outcomes. This dynamic nature highlights the absolute need for highly adaptive medical responses. What works perfectly for a rattlesnake bite in Arizona might be less effective for the same species in Texas due to these venom differences. It means that antivenom developed using venom from one geographic area may even be ineffective against bites from the same species in another area. Classic examples include Russell's viper, Daboia russellesiamensis, and the South American rattlesnake, which Crotalus terrificus. Even within a single geographic location, distinct venom types may exist among subpopulations, requiring very specific knowledge.
Then we have the family Lamprophidae, specifically the subfamily Atractospinae. This is a small but intriguing subfamily found only in Africa and the Middle East. They're distinguished by their very unique side-striking fangs, which are quite unlike anything else, and venom components like seraphotoxins. Few species significantly envenom humans, but when they do, they can cause alarming local effects, tissue necrosis, and cardiotoxicity affecting the heart.
It's also worth briefly mentioning medically important non-venomous snakes. It's easy to focus solely on venom, but let's not forget the sheer physical power some non-venomous snakes wield. While they generally cause few problems, large species like pythons and boas, family Boidae, can inflict significant mechanical bites with their many long, sharp, recurved teeth. These aren't just scratches, they can lead to deep, lacerating wounds and serious infection.
Yeah, definitely not just a scratch. And beyond bites, these large constrictors can also cause truly terrifying crush injuries by constricting the torso or neck. This can lead to internal organ damage and potentially lethal effects on the cardiovascular and respiratory systems, causing suffocation or heart failure. It's a very different kind of danger than venom, but equally serious in its own way. The idea that pythons or boas produce clinically relevant toxins for human envenoming is controversial and largely not supported by current research. Their danger truly lies in their immense physical power and their bite mechanics.
Right. So let's dive into the science of venom itself. It's truly a biological masterpiece, a marvel of natural chemistry. Snake venoms are produced in specialized venom glands, which are actually derived from salivary glands, with the exception of Duvernoy's glands and some non-front-fanged colobroid snakes we discussed earlier. Once produced, the venom is delivered via a duct to the fang base, and then into the victim. What's truly fascinating is that the ejection of venom is often fine-tuned by muscular contraction around the gland, creating intraglandular pressure. This precise control explains dry bites, where a venomous snake bites, but doesn't inject enough venom to cause significant envenoming. It's not just a warning, it's an act of choice potentially. Approximately 20–25% of pit viper bites are actually dry bites.
Interesting. On the other hand, those non-front-fanged colobroid snakes with their low-pressure Duvernoy's glands may have less precise control over venom ejection compared to the high-pressure glands of front-fanged venomous snakes like elapids and vipers. It's a less controlled, almost haphazard delivery system, you could say.
Pretty much. At its core, snake venom is not a single poison. It's an incredibly complex mixture of proteins, peptides, lipids, carbohydrates, and metal ions. Think of venom as a highly specialized biological toolkit. It contains a wide variety of enzymes, each designed for a very specific, often devastating job. For example, you have phospholipases A2, PLA2s. These are like tiny molecular drills that essentially tear apart cell membranes, causing widespread cellular damage.
Ouch.
Then there are metalloproteinases, SVMPs. These are the tissue dissolvers. They break down the structural components of tissues and blood vessels, leading to massive bleeding and local destruction. And serine proteases, SVSPs. These wreak havoc on your blood clotting system, either by making blood clot uncontrollably or preventing it from clotting at all.
So it's not just a single poison. It's a sophisticated biological weapon with multiple targeted attacks happening simultaneously. That truly paints a picture of its complexity. Beyond these enzymes, non-enzymatic proteins also play significant roles, like three-finger toxins, which can cause paralysis, seraphotoxins, which affect the heart, disintegrins, which stop platelets from clumping, preventing clotting, C-type lectin-like proteins, CLPs, which also interfere with clotting, and others like bradykinin potentiating peptides, BPPs, and vascular endothelial growth factors. It's absolutely mind-boggling how precise these biological machines are.
It really is. Fundamentally, the main roles of venom are straightforward. Prey acquisition, incapacitating a meal quickly and efficiently, and defense against predators, including humans. While predigestion of prey is a possible third function, it remains largely unproven in current research.
Now, let's revisit venom toxicodynamics and variability, because this is where the unpredictable nature of snakebite really comes into play. Venom variability is a truly crucial concept in toxinology. The content and potency of venom in a given snake can vary significantly due to fascinating factors like age. Young snakes, for instance, may have venom with different components or potency compared to adults, sometimes even more potent. Diet. What a snake eats can influence its venom composition. Geographic location. There's often marked regional variation, which is a huge challenge as it directly impacts anti-venom efficacy. Season. Even the time of year can play a role.
This inherent dynamic variability within snake venoms is precisely what makes diagnosing and treating snake bites so challenging. It forces us to constantly question assumptions and consider that even seemingly identical situations can have vastly different outcomes. This reality highlights the profound need for highly adaptive medical responses. This means that an antivenom developed using venom from, say, a specific region in South America may be ineffective against bites from the same species in a different region due to these biochemical differences. We see classic examples with Russell's viper, Daboia silesiamensis, and the South American rattlesnake, Crotellus dorissus terrificus. And yes, even within a single geographic location, distinct venom types may exist among subpopulations.
And how the venom is absorbed matters just as much, right? Venom is usually injected subcutaneously right under the skin. Systemic absorption typically occurs quite slowly, often via the lymphatic system.
Exactly. This slow lymphatic spread is crucial because it can lead to a delayed onset of systemic effects. The venom acts like a local depot, slowly releasing toxins into the bloodstream over time. Toxins targeting extravascular sites, like neurotoxins and myotoxins that need to travel to nerves or muscles, may also have a delayed onset of clinically detectable action. It's a ticking clock, but often a slow one at first.
Okay, let's move on to the clinical effects, what venom actually does to your body. Let's start with neurotoxins. These are the paralysis inducers.
Right, they're diverse polypeptide toxins, primarily causing flaccid paralysis by acting at the neuromuscular junction, that critical connection point between your nerves and muscles.
And there are two main types, and the distinction is clinically important. First, presynaptic neurotoxins, which you find in snakes like Australian and New Guinea death adders, kraits, mambas, tiger snakes, and taipans. These toxins prevent the release of acetylcholine, the chemical messenger that tells your muscles to contract. Once they've shut down that system, they can be very stubborn and are often resistant to late antivenom therapy, meaning if you don't get antivenom quickly, the damage might already be done. Mojave toxin, a specific PLA2, is a notable one found in some Mojave rattlesnake populations.
Then there are postsynaptic neurotoxins, found in the New Guinea small-eyed snake, American coral snakes, some cobras, and sea snakes. These toxins block the acetylcholine receptors on the muscle side, preventing the message from being received. The good news here is that these are often reversible with antivenom therapy, as the antivenom can bind to the toxins and free up those receptors. Clinically, neurotoxicity can lead to frightening symptoms like blurred vision, paresthesias, mitosis, progressive paralysis, and potentially fatal respiratory failure, especially in regions lacking intensive care facilities where ventilatory support isn't readily available.
Scary stuff. Next, we have myotoxins, literally the muscle destroyers. These cause local muscle damage at the bite site, but the real danger is that they can lead to widespread systemic myolysis. That means a breakdown of muscle tissue throughout the body.
Yep. Exactly. Systemic myolysis results in intense muscle pain, tenderness, generalized weakness, and a telltale sign: myoglobinuria. That's where muscle breakdown products are excreted in the urine, making it appear red to muddy brown. Myotoxic PLA2 enzymes are significant contributors to this devastating muscle damage.
And of course, there are toxins affecting blood coagulation, often called hemotoxins. These are the blood disruptors. Snake venoms contain an incredibly complex array of components that interfere with hemostasis, which is your body's natural process for stopping bleeding. This includes procoagulants, anticoagulants, and fibrinolytic agents. It's like a biochemical wrench thrown into a finely tuned machine.
Absolutely. Some venoms contain what we call procoagulants. Imagine your blood has a limited supply of clotting material. These procoagulants rapidly trigger your body to use up all that material, like a fire alarm that makes everyone rush out. So if you then get another injury or even just internal bleeding, your body has no clotting factors left to stop it. That's consumption coagulopathy. Other toxins are anticoagulants, which actively prevent blood from clotting, while fibrinolytic agents cause the breakdown of existing clots or fibrin. Many viper species cause both coagulopathy and hemorrhage. In North American Crotalinae envenomation, surprisingly, anticoagulant effects often predominate, making clotting difficult. The variations in Achistrodon species venoms, for instance, significantly affect their anticoagulant effects, directly impacting clotting times and fibrinogen levels, which are critical for diagnosis.
Then we have hemorrhagens. These are generally zinc metalloproteinase that directly damage the vascular endothelium, the lining of your blood vessels, promoting widespread bleeding. They are potentially lethal. Some venoms also contain nephrotoxins, which directly affect the kidneys, though secondary renal damage from shock or myolysis is actually more common. And necrotoxins cause severe local tissue injury and necrosis, or tissue death, around the bite site. This is common in vipered bites, but also in certain elapids like African and Southeast Asian cobras. PLA2 toxins, once again, play a major role in this local damage. Other toxins like disintegrins and C-type lectin-like proteins specifically affect platelets, which are crucial for initial blood clotting.
This highlights a truly critical lesson for anyone dealing with snake bites. Never assume a snake bite will follow a textbook presentation. The venom's complexity means you're dealing with a dynamic, multi-system assault. Recognizing these varied and often overlapping effects is paramount for effective medical care. The old simplified notion that elapids are purely neurotoxic and viperids are purely hemorrhagic is demonstrably inaccurate and should be abandoned. Many elapids can cause hemostatic issues or severe local injury, and some viperids can cause primary neurotoxic paralysis. North American pit viper venoms, for example, can simultaneously damage tissue, affect blood vessels and blood, and alter neuromuscular transmission. It's a total body assault.
Okay, moving on to local effects. These are often the first, most visible signs of envenomation at the white site. When venom is deposited subcutaneously, right under the skin, it typically leads to a rapid onset of these local effects. Local swelling, or edema, is a characteristic feature, often progressing very rapidly. The speed and extent of this swelling can be a key indicator of severity, especially for locally active venoms, which many viperids possess. Interestingly, in some cases, this swelling can even be delayed by 8-12 hours.
That's right. Other common local signs include erythema, or redness, and ecchymosis, which is bruising, and a general discoloration around the bite, sometimes quite dramatic, like an entire foot appearing bluish. Hemorrhage and blistering, which can sometimes be hemorrhagic themselves, are also common. Frank necrosis, or tissue death, is a severe outcome common in many viperid bites, but also in certain elapids, most notably some cobra species from Africa and Southeast Asia.
Local pain is also almost universally present, but here's a crucial nuance. It's not always a reliable indicator of significant envenoming. Why is that? Because its intensity can vary so much, and a person's anxiety level can also influence perceived pain. Some Texas coral snake envenomations, for example, are primarily characterized by painful paresthesias or tingling sensations rather than dramatic swelling.
Good point. While not definitive, fang marks are almost always present as 1 or 2 puncture wounds, small lacerations, or scratches. However, they can be very small or even absent, especially with colubrids and smaller elapids, which makes diagnosis harder. Sometimes, the only visible sign is the ability to express a small drop of blood from the bite site.
So this is a huge takeaway for our listener. If you get bitten and you don't see much happening locally, no dramatic swelling or bleeding, you still absolutely cannot just brush it off. That goes against what a lot of people might assume, thanks to movie portrayals.
Absolutely. The lack of a dramatic local response should never be assumed to indicate a trivial bite, unless the snake species is known to cause significant local effects in all medically noteworthy cases. Local swelling may be completely absent after bites by many elapids. Coral snake envenomation, as we've noted, typically results in minimal local signs or only mild swelling and paresthesias compared to the aggressive local reactions of pit viper envenomation.
Right.
That's a critical point for the learner. The absence of a dramatic local reaction does not mean you're in the clear, especially with certain species like the coral snake, where the real danger is silent and systemic. It's the hidden effects that can be the most insidious.
Okay. When we look at snake species and their associated local effects, viperids and crotalids are indeed well known for causing significant local tissue injury and necrosis. Think of the African puff adders, gaboon vipers, and our own North American pit vipers. Copperhead envenomation, for instance, often sees its primary clinical manifestation limited to the progression of this local tissue damage.
Conversely, while many elapins are classically associated with neurotoxicity, some, like African and Asian cobras or the African ring-call spitting cobra, can actually cause very severe local effects, including extensive necrosis. However, it's vital to remember that North American coral snakes typically do not cause significant local tissue effects, or only very mild swelling and paresthesias, as we've emphasized.
Got it. The toxicological basis of these local effects is complex, as you'd expect, involving multiple venom components working in concert. Metalloproteinases, or SVMPs, are key contributors. They lead to inflammation, break down proteins, proteolysis, and cause hemorrhage by directly damaging the vascular endothelium and increasing vessel permeability. This increased permeability is what leads to the rapid edema and bruising we see, and they also directly cause skin necrosis.
Another enzyme, hyaluronidase, plays a nasty role by aiding venom spreading. It does this by disrupting the extracellular matrix, the glue between your cells, which effectively allows the venom to spread more rapidly through tissues, significantly contributing to the widespread swelling. Phospholipases A2, or PLA2s, as we discussed earlier, also play a major role in local tissue damage and necrosis. And serine proteinases, SVSPs, may also contribute to the inflammatory response. The combined action of these toxins leads to severe capillary basement membrane damage, resulting in pronounced edema and ecchymosis.
So given all this complexity, how do medical professionals actually assess these local effects to determine the extent of envenoming? It sounds like a meticulous process.
It absolutely is. It's vital for determining the extent of envenoming. They rigorously examine the bite site for any puncture marks, assessing the swelling, its rapidity and extent, bruising, discoloration, blistering, and any developing necrosis. They also check for pain and tenderness, which can sometimes extend surprisingly far along lymphatic pathways, and look for enlarged or tender lymph nodes. This meticulous, continuous monitoring is crucial, almost like a medical detective trying to predict the venom's next move. It truly underscores the multi-system impact of envenomation and why a holistic, long-term approach to patient care is paramount. It's not just about the acute crisis, but the aftermath as well.
Let's transition to a truly critical phase in managing a snake bite diagnosis. It's really about solving a medical mystery under pressure. Upon presentation, healthcare professionals have 3 fundamental diagnostic questions that they must address immediately. First, and perhaps most basic, is this actually a snake bite, or could it be another condition mimicking it?
Right. Second, assuming it is a snake bite, the next question is significant envenoming actually present, and if so, to what extent? Many venomous bites are dry bites or only cause minor effects. And third, the often trickiest part, what type of snake was responsible? This can be incredibly difficult, as we'll discuss.
Okay. When it comes to laboratory investigations, even in smaller or rural hospitals with limited resources, some basic tests are invaluable for initial assessment. Urinalysis, for example, is critical. It's used to check for hemoglobin or myoglobin in the urine, both of which test positive for blood. Microscopy can then help differentiate between actual red blood cells and myoglobin, indicating muscle breakdown.
A simple but incredibly useful bedside test, especially in resource-limited settings, is the whole blood clotting time, or WBCT, and the 20-minute whole blood clotting test, or 20-WBCT. This is precisely what it sounds like. You draw blood and see if it clots. If blood fails to clot or forms only a weak clot by 15-20 minutes, then coagulopathy, a major clotting disorder, is highly likely present. This immediate bedside information is invaluable when more advanced lab tests aren't immediately available.
Makes sense. For regional or teaching hospitals with full laboratory facilities, more advanced tests are performed to get a comprehensive picture. These include extended coagulation studies like PTINR, prothrombin time international normalized ratio, APT, activated partial thromboplastin time, fibrinogen levels, and D-dimer. All of these help assess the specific clotting factors at play, and derangements are very common in Crotolini envenomations.
A complete blood count, or CBC, is also vitally important to assess overall blood components, especially platelet count. Thrombocytopenia, meaning a platelet count below 120,000 per cubic millimeter, is a common finding after envenomation. We also look at absolute lymphocyte counts. Electrolytes, urea, and creatinine are assessed to check renal function, as the kidneys can be affected, especially with severe muscle damage or myolysis. And creatinine phosphokinase, or CPK, specifically detects and quantifies muscle damage throughout the body.
What about specialized tests for venom detection? Can doctors just run a quick test to see what venom is present? Is that a thing?
Well, currently, the only widely commercial system is the Australian CSL Snake Venom Detection Kit, which uses an ELISA-based test for Australian and New Guinea snakes. It uses a bite site swab or urine and provides a qualitative result to guide specific antivenom. However, a crucial point is that a negative result from these kits does not definitively exclude envenoming, and a positive result doesn't necessarily indicate significant envenoming or a definite need for antivenom. In North America, commercial assays for direct venom detection in wounds are unfortunately not commercially available for early diagnosis or routine clinical management, though research assays do exist. It's definitely a gap in our current diagnostic toolkit.
Huh. So the importance of serial testing cannot be overstated then. It sounds like this isn't a one-and-done kind of diagnosis.
You're absolutely right. Snake envenomation is an incredibly dynamic process. Initial findings rarely represent the peak severity. It is absolutely vital to repeat tests, even if initial results are normal, to detect the late development of envenoming, particularly coagulopathy, which can creep up hours after the bite.
Can you give us a concrete example of this serial testing? Like how often?
Certainly. For example, if initial exams and tests are normal, retesting is strongly recommended at 2 hours, then again 3 hours later, which would be the 5th hour after initial assessment. For patients with puncture wounds but no initial swelling or envenomation signs, what we might initially suspect as a dry bite, an observation period of at least 8-12 hours is absolutely necessary due to the possibility of delayed symptom onset. For Acastrodon bites, copperheads, and cottonmouths, 8 hours is often sufficient. For rattlesnake bites, 12 hours is recommended.
And if nothing happens within that observation window, then you're likely okay.
If no swelling develops and labs remain normal after at least 8 hours, then a dry bite is indeed likely, and the patient may be safely discharged. However, specific systemic effects like coagulopathy can persist, develop late, or even recur, necessitating retesting over several days, sometimes even after discharge. This dynamic process is why continuous vigilance is so crucial.
This raises an important question. Why is it so hard to just identify the snake and know what to do? The reality sounds like the diagnostic journey is a methodical process of exclusion and careful observation, far more than just looking at the bite. Dry bites, which are about 20–25% of pit viper bites, are impossible to definitively diagnose without extended observation because symptoms can be so delayed.
Precisely. And the inherent variability in clinical presentation, influenced by snake species, the quantity and potency of venom injected, the bite location, and individual patient factors makes it even harder. Snake identification is often unknown by the victim, and visual descriptions are notoriously unreliable. Attempts to capture or kill snakes, while understandable, are strongly discouraged due to the extreme danger this poses to the victim or rescuer.
Right? Don't be a hero. Finally, general symptoms like headache, nausea, vomiting, or abdominal pain can certainly indicate envenoming, but they may also be due to the overwhelming anxiety associated with the bite. Differentiating true envenoming from anxiety is crucial and requires careful clinical judgment. And as we've already emphasized, the absence of local signs does not rule out significant envenomation, especially with certain elapids like coral snakes, where local signs are often minimal, but the systemic danger is profound. Some rattlesnake envenomations can even cause significant thrombocytopenia or coagulopathy without much appreciable swelling, underscoring this point.
Okay, now for something critically important for everyone to understand. First aid and initial hospital management. This is where we clear up a lot of misconceptions. The only universally accepted and recommended first aid measure for snakebite, applicable globally, is immobilizing the bitten area or limb and keeping the victim as still as possible. While not proven by randomized clinical trials, extensive anecdotal evidence and physiological understanding strongly support its benefit by slowing venom spread.
So just stay calm and still makes sense.
Exactly. Pre-hospital, if transport is prolonged, IV fluids may be given for systemic effects like diarrhea or weakness, and analgesics, preferably opioids, are recommended for severe pain. Gentle cleaning of the bite wound is also important. But the fundamental overarching priority is always rapid transport to a medical facility capable of anti-venom administration. Time is absolutely of the essence.
The pressure immobilization method, or PBI, is an interesting and often debated first aid technique. Its mechanism is quite clever. It aims to retard venom transport in the lymphatics by applying moderate local and limb pressure to occlude superficial lymphatics and inhibiting the muscle pump action.
Right. If correctly applied with elasticized bandages, preferred over crepe, PPI can be safely left on for several hours and is experimentally as effective as a tourniquet in preventing venom movement, but far safer. It's generally recommended for bites by many elapids, though notably not most cobras and some viperids. There's even promise for universal acceptance with a modification using a local pressure pad for viper bites in Myanmar without increasing local tissue injury. However, current universal acceptance for all viper bites is hindered by valid concerns that localizing necrotic venom might actually worsen local tissue necrosis.
Okay, so this is like the Mythbuster segment of snakebite first aid. Everything you've seen in the movies. Probably wrong and potentially dangerous. Suction and cutting are definitely out. Let's be absolutely clear. Tourniquets are no longer recommended. They are easily misused, are only effective for far too short a period, and carry a very high potential for severe injury, like ischemic necrosis, gangrene, and even amputation, all of which are worse than the bite itself.
And to further debunk the myths, suction, whether oral or using mechanical devices often sold as snakebite kits, is entirely inappropriate. Mouth suction risks transferring venom or bacteria to the person providing aid, and mechanical suction kits remove negligible venom while actively disrupting local tissues, potentially making things worse. Incision or excision of the wound also adds further injury, paradoxically increases venom absorption, and carries a significant risk of major hemorrhage, especially if the patient already has a coagulopathy.
Then there's electrotherapy, or applying local electric shock, which is considered a charlatan treatment with no proven efficacy whatsoever. Applying ice or cryotherapy is also without merit and associated with tissue damage. Topical agents applied to the bite lack human study confirmation, and traditional healing practices like snake stones have no rational basis in science. These unproven practices often delay definitive medical care, which is the real life-threatening danger.
Definitely. When it comes to specific considerations for North American snakes, there's a crucial difference for PBI. For North American Crotalinae, our pit vipers, pressure immobilization bandages, PIBs, should not be used. Studies have shown they can significantly increase compartment pressures and lead to more tissue necrosis due to the substantial local tissue damage these venoms cause. Pre-hospital care for pit viper bites focuses solely on limb immobilization, establishing IV access and rapid transport to a definitive care facility.
Okay, so no PBI for pit vipers in the U.S. But for North American coral snakes, unlike crotalid bites, PBI is reasonable, especially if transport to a hospital is prolonged. Worsening local tissue injury isn't a concern with coral snake venom, as its effects are primarily neurotoxic, and PIVs can effectively delay systemic absorption of that dangerous neurotoxic venom. If a PIV is in place, it should be left there until resuscitative equipment and antivenom are available at the hospital.
Correct. Once a patient arrives at the hospital, basic and supportive care is absolutely paramount. The immediate priority is to critically assess and stabilize vital systems, focusing on airway, breathing, and circulation, ABCs. For patients with respiratory distress, oxygen supplementation should be initiated, and preparations for endotracheal intubation should be made if respiratory status worsens or bulbar paralysis develops, especially critical with coral snake envenomation. Early and aggressive management of the airway is mandatory.
Circulatory support and IV access are also critical. An IV line should be inserted, ideally in an unaffected extremity, and an initial IV fluid load given, especially for fluid shifts or hypovolemic shock resulting from the local reaction. It's wise to consider a line suitable for repeat blood sampling, but to avoid femoral, jugular, or subclavian vessels if coagulopathy is suspected due to the high bleeding risk. Regular monitoring of pulse, blood pressure, and cardiac rhythms is absolutely essential.
Pain management typically involves using opioids for acute pain due to the theoretical risk of worsening hematological toxicity with NSAIDs like ibuprofen. For wound care, the bite wound should be gently cleaned and debridement performed if tense bullae are present. Tetanus immunization status should always be assessed and updated, but intramuscular IM tetanus boosters should be avoided if coagulopathy is present, again due to the risk of hematoma.
Immobilization and elevation of the bitten limb are also key. The limb should be immobilized in a padded splint in near full extension. Elevating the affected extremity above the level of the heart is recommended, as it appears to significantly decrease dependent edema and reduce pain, which is a simple but effective intervention.
And perhaps most crucial in the hospital setting is continuous monitoring for envenomation progression. Patients should be regularly assessed for developing paralysis, coagulopathy, myolysis, or renal failure, even if they were initially asymptomatic. A very practical tip. Medical staff will mark the leading edge of tenderness, erythema, and swelling, and reassess every 15-30 minutes to track progression. Urine output should also be meticulously monitored.
What's the recommended observation period in the hospital again?
An observation period of 8-12 hours is necessary for patients with puncture wounds, but no initial swelling or other envenomation signs, as delayed onset is a very real possibility. If no swelling develops and labs remain normal after at least 8 hours, then a dry bite is likely, and the patient may be safely discharged. This systematic approach in the hospital is critical. As you can see, the level of detail required for continuous monitoring is almost like a medical detective trying to predict the venom's next move.
Okay, let's talk about antivenom. This is the big one, right? The lifesaver.
It absolutely is. Antivenom is the cornerstone of management, the definitive and only specific treatment for envenomation. Its mechanism is quite elegant. It works by binding to and neutralizing venom antigens, preventing their toxic effects and enhancing their elimination from the body. It can halt the progression of tissue damage and reverse certain venom effects like coagulopathy, but here's a crucial point. It generally does not reverse existing tissue injury or prevent necrosis that has already occurred. It's about stopping the ongoing damage, not repairing what's already done.
Gotcha. Stop the bleeding, stop the paralysis, but it won't magically heal dead tissue. And this is a truly crucial principle. Despite financial burden and the potential for adverse reactions, antivenom should never be withheld from a patient who needs it. The risk of untreated envenomation is typically far greater and more devastating than the risk of antivenom reactions. That's a powerful commitment to patient care.
Absolutely. For North American pit viper envenomations, we currently have 2 FDA-approved antivenoms available. The first is Crotalidae Polyvalent Immune Fab, FEBAV, marketed as CroFab. This is an ovine-derived, meaning sheep-derived, antivenom. It's produced by immunizing sheep with venoms from 4 specific North American pit viper species: Crotalus adamantius, Crotalus atrox, Crotalus cucullatus, and Acastrodon piscivorus. The Ig antibodies from the sheep are then treated with papain to yield Fab fragments, which lack the Fc region of the antibody. This modification contributes to reduced immunogenicity, meaning fewer allergic reactions.
Okay, crofab from sheep. It's approved for the management of all North American pit viper species. Regarding dosing, the manufacturer recommends an initial dose of 4-6 vials, though evidence-based consensus, often from toxicology experts, suggests a higher initial dose of 8-12 vials for patients in shock or with serious active bleeding. Additional 4-6 vial doses are then given until initial control is achieved, meaning the arrest of local tissue effects, clear improvement in hematologic effects, and resolution of systemic signs.
Right. Once initial control is achieved, maintenance doses of 2 vials every 6 hours for 3 doses, totaling 6 additional vials over 18 hours, are recommended by the manufacturer in some guidelines to prevent recurrence of symptoms. However, there's an ongoing debate on this maintenance dosing strategy, with not all practitioners using it routinely, especially for less severe copperhead envenomations. An alternative, called a PRN, prorenata, or as-needed dosing strategy for rattlesnakes, involves observing the patient carefully and only giving additional antivenom if progression of symptoms occurs. A retrospective study found that this PRN strategy used significantly less antivenom, median 8 vials versus 16 vials, and resulted in shorter hospital stays, median 27 hours versus 34 hours, with no significant differences in readmission rates, retreatment needs, bleeding, or surgical complications. This finding truly challenges the need for routine maintenance and requires frequent expert reassessment of patient.
Interesting trade-off. A known complication with crofab, despite even using maintenance dosing, is something called late hematologic toxicity, with maybe a 28.5-32% incidence in some patient groups. This is often due to a pharmacokinetic mismatch where the Fab fragments of the antivenom are cleared from the body faster than the venom itself, so the venom can sort of re-emerge.
It's a good way to put it, yeah. Patients are carefully monitored with platelet and coagulation studies 2-3 days and 5-7 days after the last antivenom dose. If these tests show abnormalities, they are retreated with a 2-vial dose of antivenom.
Okay. And the second FDA-approved antivenom is Protalide Immune, FA2, equine, marketed as NVP. This one is equine-derived or horse-derived. Horses are immunized with venoms from 2 potent South American pit viper species, Bothrops asper and Crotalus dorissus. The antibodies are treated with pepsin to produce FA2 fragments. These fragments also lack the FA2 region, but critically they retain a hinge region, which gives them a significantly longer half-life in the body compared to the Fab fragments of crofab.
That longer half-life is key. Anavib was FDA approved in 2015. With its approval expanded in 2021 to include Acastrodon species, effectively covering all North American pit viper envenomation, including rattlesnake, copperhead, and cottonmouth water moccasin bites. The dosing per package insert is an initial dose of 10 vials, repeated as needed. Maintenance involves 4 vials as needed during an 18-hour observation period. A significant advantage of Anavib touted in clinical trials is its reduced late hemotoxicity, showing significantly lower rates of late coagulopathy and thrombocytopenia, around 5-10%, compared to crofab, which is closer to 30%.
So maybe fewer late problems with Anavib due to that longer half-life. This leads to a fascinating and crucial principle in antivenom dosing. Children require the same dose of antivenom as adults. It might seem counterintuitive at first, since medical dosing for most medications is based on body weight, but for antivenom, dosing is based on the venom load, not the patient's body weight. So what does this all mean for our listener? The fact that a child needs the same dose as an adult really hammers home that it's about neutralizing the venom itself, that specific biological burden, not compensating for body size. That's a powerful aha moment for thinking about toxicology. It's a specific antigen-antibody reaction, not a weight-based drug effect.
Exactly. It underscores that we are targeting the venom directly, irrespective of the patient's size. Now let's talk about the efficacy and safety considerations with antivenom balancing the immense benefits with the potential risks. Historically, older, unprocessed whole equine IgG antivenoms had very high acute and delayed allergic reaction rates, sometimes reported as high as 83%. Thankfully, modern production processes have significantly improved safety. For Crotalidae polyvalent immune Fab, crofab, acute reaction rates range from 1.4% to 8%.
That's much better. However, Crotalidae immune FE may be associated with a higher incidence and severity of acute hypersensitivity reactions, or AHRs, including anaphylaxis. One study, for instance, reported AHRs in 14.7% of Fab2A patients compared to 3.8% in Fab patients. These reactions typically occur during or shortly after infusion, and symptoms can include rash, which is often the most frequent symptom and can be a precursor to more severe anaphylaxis, itching, hives, swelling of the face or throat, angioedema, bronchospasm, difficulty breathing, hypotension, low blood pressure, and in rare but severe cases, anaphylactic or anaphylactoid shock.
And recently, research highlights a truly concerning and surprising correlation between AHRs to antivenom and alpha-gal syndrome, or AGS. This is a pre-existing allergy acquired through tick bites, specifically to a sugar molecule called galactose alpha-1,3-galactose, or alpha-gal. Both ovine-derived crofab and equine-derived anavip contain alpha-gal, meaning a tick bite can prime a person to react severely to a life-saving snakebite treatment.
Whoa. That's a fascinating and rather unsettling connection between something as common as a tick bite and a rare but critical medical emergency like a snake bite. A Toxis North American Snakebite Registry study found that AHRs were more common overall with Anavip, 6.6%, than with Crofab, 2.9%. But this difference was especially notable in states with a higher prevalence of AGS, where Anavip showed a striking 22.2% AHR rate versus Crofab's 3.3%. This suggests that the pepsin digestion used in Anavip manufacturing might not break down the alpha-gal oligosaccharide as effectively as the papain in Crofab, leaving more of the allergenic sugar. Higher initial doses of Anavip may also contribute to increased AHRs. It's also important to note that AHRs can occur on first exposure and are not always IgE mediated.
Right. If an AHR occurs, the antivenom infusion must be stopped immediately. Treatment involves administering epinephrine, either by 4V infusion, subcutaneous, or intramuscular injection, oxygen, 4V fluids, antihistamines, and corticosteroids. Once the acute reaction is controlled, the antivenom infusion can be cautiously restarted, often by titrating against epinephrine as needed. A critical point here, and one that often surprises people, is that pretesting for antivenom allergy is unreliable and not recommended. It can actually cause anaphylaxis itself, often fails to predict reactions, and can even sensitize the patient. Premedication with antihistamines or steroids is generally not of proven value in preventing these reactions.
Okay, so no skin test beforehand. Then there are delayed adverse effects known as serum sickness. This is a type 3 immune complex hypersensitivity reaction, typically occurring for 14 or more days after antivenom administration, sometimes even up to 3 weeks later. It's characterized by a classic triad of symptoms: a rash, joint pains, arthralgias, fever, and general malaise. More severe but rare cases can include glomerulonephritis affecting the kidneys or vasculitis.
The risk of serum sickness is directly related to the total foreign protein load, meaning the number of vials of antivenom administered. Treatment typically involves corticosteroids, like oral prednisone, often tapered down over time, and Ogor antihistamines. The crucial principle here, once again, is that the risk of serum sickness, while uncomfortable, is far less than the risk of untreated envenomation. Antivenom should never be withheld due to these concerns.
Right, the bite is usually worse. Another significant complication, especially with crotaline envenomation, like rattlesnake bites, is the recurrence or late onset of coagulopathy or thrombocytopenia weeks after initial treatment, which can lead to life-threatening bleeding. This is attributed to that pharmacokinetic mismatch we mentioned earlier, the faster clearance of Fab antivenom than venom, or delayed venom absorption from the bite site.
Exactly. Maintenance doses are recommended to preclude this, but it can still occur. Therefore, careful outpatient follow-up with serial platelet and coagulation studies, for example, 2-3 days and 5-7 days after the last antivenom treatment for rattlesnake bites, is crucial. If these parameters become abnormal, retreating with antivenom, for example, a 2-vial dose initially, is recommended. Importantly, blood product replacement, like fresh...
Okay, so hold the FFP unless absolutely necessary. Other important considerations for antivenom use include cost. Antivenom therapy, especially Crofab, is notoriously expensive, which leads to ongoing discussions about the necessity and cost-effectiveness of maintenance dosing strategies. However, as we noted, PRN strategies can potentially reduce both cost and hospital stay without negative patient outcomes. It's also vital to remember that antivenom halts progression but does not reverse existing tissue injury or prevent necrosis that has already occurred.
And for pregnant patients, antivenom is indicated with the same criteria as non-pregnant patients, though they should be monitored closely for light hemotoxicity due to the potential risk of spontaneous abortion. Now, regarding drug interactions, patients on beta blockers may be less responsive to epinephrine for anaphylaxis, which is an important consideration if an AHR occurs.
Let's specifically address North American coral snake envenomation and its specific antivenom, NACSAV, North American coral snake antivenin. We mentioned this earlier, but it deserves a closer look. Coral snake bites primarily cause neurotoxicity, often, as we emphasized, without significant local tissue injury or hematologic effects. But the neurotoxic paralysis, including severe respiratory paralysis, can develop quickly and may not be reversible once symptoms fully manifest.
That's the danger. North American coral snake antivenom, NACSAV, was historically manufactured by Wyeth and is now provided by Pfizer on an as-needed basis. Supplies are limited and located via the Antivenom Index, a critical resource. NACSAV is indicated for symptomatic patients with coral snake envenomation manifesting any neurologic abnormalities, such as paresthesia, slurred speech, drooping eyelids, xeratosis, or paralysis. Crucially, it is not indicated for local swelling, paresthesias, or pain alone, and empiric administration to asymptomatic patients is now contraindicated, given the risks associated with the antivenom itself.
Okay, so only if neurological symptoms appear. The initial recommended dose is 3 to 5 vials mixed in 250 milliliters of 0.9% saline and administered intravenously over 1 hour. Additional doses are indicated for the evolution of any new or worsening neurologic abnormalities, with up to 10 vials potentially administered. However, as an equine-derived whole IgG product, NACSAV carries a significant risk of immediate and delayed allergic reactions, including anaphylaxis and serum sickness. Once again, pretesting for allergy is useless and dangerous.
Right. If NCSAV is unavailable, which can happen due to limited supply, supportive care, including mechanical ventilation for respiratory failure, is the absolute mainstay. While terrifying, the paralysis is completely reversible, though recovery can take many weeks. Acetylcholinesterase inhibitors like neostigmine may be trialed if antivenom availability is delayed, as they can sometimes help temporarily with the neurological symptoms. What's truly fascinating here is the distinct difference in treatment approach between pit viper and coral snake bites. It truly emphasizes that while both are venomous, the mechanism of their venom dictates entirely different first aid and antivenom strategies, demanding specific knowledge and response. #, treating specific complications and follow-up.
So let's look at treating specific complications that arise from snake envenomation. For paralysis and respiratory failure, early detection and adequate antivenom are crucial to prevent progression.
Yes. If severe paralysis is already established, especially from non-reversible presynaptic neurotoxins, the focus shifts to intubation and mechanical ventilation to support breathing. Intubation is preferred over tracheostomy if coagulopathy is present due to the bleeding risk. It's also vital to remember that patients may remain fully conscious despite complete paralysis, necessitating careful attention to their psychological needs and communication.
Right, that must be terrifying. For coagulopathy and hemorrhage, the primary management involves neutralizing circulating procoagulant or anticoagulant venom components with adequate antivenom. It sounds like the antivenom itself is the key here.
Precisely. Routine replacement of depleted coagulation factors and fibrinogen with products like fresh frozen plasma, FFP, is generally not advisable while active venom is circulating, as it can actually worsen fibrinolysis and bleeding. Such replacement therapy should only be considered after procoagulants are neutralized, evidenced by improving coagulation parameters, or in cases of truly catastrophic life-threatening bleeding where the patient is exsanguinating. Copperhead envenomations, for instance, average less severe initial coagulation derangements, but still require careful monitoring.
And what about local tissue injury and compartment syndrome? We know that snake venom can cause horrific tissue damage.
Local necrosis typically requires conservative care, meaning wound management, but antivenom should be administered to minimize further damage. A critical point for clinicians, and often misunderstood, is that fasciotomy, a surgical procedure to relieve pressure, is frequently overused in snakebite management and often results in significant long-term functional deficits. It should only be performed when there is absolute unequivocal evidence of a significant compartment syndrome, ideally confirmed by intracompartmental pressure measurements, and any coagulopathy has been completely controlled or reversed. If elevated compartment pressure is noted but distal perfusion continues, administering additional antivenom is a very reasonable initial step to try and lower the pressure and potentially avoid unnecessary surgery.
Okay, so fasciotomy is a last resort, basically. What about infection? Does a snake bite commonly lead to infection?
Interestingly, secondary infection is not a routine complication of snakebite, despite common perception. Therefore, antibiotics should only be used when clearly indicated, ideally after culture and sensitivity studies have identified a specific pathogen. Tetanus immunization status should, however, always be assessed, and a booster given as soon as safely possible, but avoiding intramuscular IM injection if coagulopathy is present due to hematoma risk.
Right, and just to reiterate for our listener, those late hematologic effects we discussed, like recurrent or late-onset thrombocytopenia or coagulopathy, can indeed occur weeks after initial treatment, especially with rattlesnake bites treated with Profab. This can potentially lead to life-threatening bleeding episodes.
That's why careful outpatient follow-up with serial platelet and coagulation studies, for example, 2-3 days and 5-7 days after the last antivenom treatment for rattlesnake bites, is absolutely crucial. Patients are also advised to avoid surgical or dental procedures and high-risk activities until their blood parameters have returned completely to normal. And for serum sickness, that delayed hypersensitivity reaction, it's typically managed with oral prednisone and H1 receptor antagonists, usually on an outpatient basis.
For special populations, it's worth noting that pregnant patients should receive antivenom using the same criteria as non-pregnant patients, though they require very close monitoring for late hemotoxicity due to the risk of spontaneous abortion. And as we highlighted earlier, pediatric patients require the same dose of antivenom as adults based on venom load, not body weight.
Finally, exotic or non-native, snake envenomations, perhaps from a hobbyist collection, require immediate expert consultation from poison control centers, zoos, or specialized herpetologists for identification and specific treatment guidance. Hospitals generally cannot stock non-FDA-approved exotic antivenoms, often requiring emergency investigational new drug, IND, applications from the FDA to access them. Pharmacists play a truly critical role in sourcing, preparing, and administering these specialized antivenoms under unique circumstances, and close ICU monitoring is always preferred.
Wow, okay. That adds another layer of complexity. And for discharge and follow-up, what's the typical protocol?
Patients should not be discharged until their envenomation and any complications have clearly resolved, a comprehensive follow-up plan is established, and they are thoroughly educated about serum sickness symptoms and the need for immediate medical review if those symptoms appear. Follow-up appointments are typically scheduled for 1 and 2 weeks post-discharge to ensure complete recovery and catch any lingering issues. #TagTagOutro.
So what does this all mean? We've really taken a true deep dive today into the complex world of snake envenomation. I mean, from understanding its surprising global burden to the microscopic, devastating dance of venom components and the incredible cutting-edge science behind saving lives.
It really is. Snake envenomation is a truly dynamic and incredibly complex clinical scenario that demands a multidisciplinary, highly informed approach. The inherent variability in venoms and patient responses necessitates a tailored and vigilant approach to care, reinforcing that there's always more to learn and adapt to in this field.
Yeah, absolutely. Our sources really emphasize that pharmacists, doctors, and healthcare providers have to stay on top of the latest evidence-based guidelines, because this field is constantly evolving, isn't it? With new insights and challenges emerging all the time.
It really is, and critical thinking is so essential in a world of information overload. As we've seen, what might seem intuitive, like applying suction to a snake bite, can actually be harmful, sometimes profoundly so. It fundamentally challenges us to look beyond assumptions and rely on robust scientific evidence.
That's a powerful thought to leave you with, our listener. In a world where we're increasingly encroaching on natural habitats and, exotic animals are part of hobbyist culture, understanding these complex biological interactions becomes more vital than ever. What does the fascinating story of alpha-gal syndrome and its unexpected link to antivenom reactions tell us about the surprising ways our environment can shape our health and the very treatments we rely on? It's a reminder that nature is always teaching us something new, sometimes in the most unexpected ways. Until next time, keep digging deeper, stay curious, and keep learning.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.